It gives me tremendous pleasure today to introduce our first speaker, Dr. Robert Wong. Dr. Wong is Clinical Associate Professor of Medicine in the Division of Gastroenterology and Hepatology at Stanford University, and he's a staff physician of Gastroenterology and Hepatology section at the Veterans Affairs Palo Alto Healthcare System. And Dr. Wong is a clinician, but also a clinical investigator with expertise in epidemiology. And his clinical interests include management of patients with a variety of complex liver disorders, including viral hepatitis, hepatocellular carcinoma, and non-alcoholic fatty liver disease. But his research, which he's going to discuss today, focuses on the epidemiology and outcomes of patients with chronic liver disease and healthcare disparities among underserved minority populations. And so it's my great pleasure to turn it over to Dr. Wong. Thank you for being here today.
Great. Thank you so much for the nice introduction. And it's an absolute pleasure and honor to be part of this program. I'm going to go ahead and share my screen here. Perfect. That looks good. So yeah, I think following on yesterday's conference into today, my talk today will focus on healthcare disparities in liver disease. And while the focus of this conference is on HCC, I'm going to take a little bit of a different approach and try and focus on healthcare disparities that are present and affect patients earlier in the cascade, especially in patients with predisposing factors to HCC, and also focusing on the early step of HCC screening. Here are my disclosures. So objectives of my talk this morning are to understand the complex cascade of care for patients with chronic liver diseases that ultimately can lead to HCC. I'm going to try to illustrate some healthcare disparities that are experienced primarily or particularly by ethnic minorities and underserved vulnerable populations. And in doing so, I'm going to try and focus on three specific areas in the next 20 minutes or so. And that's on disparities in hepatitis B, Hep C, and also HCC screening in cirrhotic populations. So as all of you here know, chronic liver diseases patients are uniquely vulnerable populations. And across the country, we see that the majority of these patients affected comprise of ethnic minorities and underserved low socioeconomic status groups. We know that there's a high prevalence of risk factors such as alcohol or drug use that not only predispose to liver disease progression itself, but also contribute to disparities in timely access to healthcare. These are data that you know, and most recent WHO estimates suggest that global Hep B prevalence is probably closer to 296, almost 300 million worldwide. But this figure here really illustrates the diversity of the Hep B population, with the majority of the global Hep B population in Asia Pacific and African regions. A study we recently published looked at the ethnic makeup of US Hep B patients. And as can be illustrated in this map, we see that the vast majority, as expected, of hepatitis B patients in the US come from international countries, primarily Asia Pacific regions, as you can see here, and African regions. And that's so important because it really stresses to us a few important facts. Number one, to understand and realize the importance of screening hepatitis B in these populations, but also be cognizant of potential healthcare disparities that these patients already exist due to disparities in access to care and their safety net population experience. In the US, not just ethnic minorities, but this is a study published about a year ago that also emphasizes the high-risk populations we see in hepatitis B. And in fact, we see here that there's a relatively high prevalence of Hep B in homeless individuals, prisoners, people who inject drugs, co-infection with HIV, and also some veteran populations, although a little bit less prevalent than other risk groups. It really emphasizes the diverse nature of Hep B patients and the importance of understanding the underlying disparities that these patients may experience. The Hep B cascade, I'm going to be using this framework a couple of times in this talk. It really tries to illustrate the complex cascade that our liver disease patients experience. And this is a cascade that's put together to illustrate hepatitis B. It's not as simple as it seems, and you can see here from the early stage of even screening, subsequently leads to diagnosis, linkage to care, not just linkage, but continued retention for monitoring, assessment for treatment, actually getting access to Hep B treatment, successful treatment, and then ultimately the goal of reduced risk of disease progression to cirrhosis and hepatocellular carcinoma. And as you can see here in these oval boxes that I created throughout the cascade, there are so many potential opportunities for patients to fall out of the cascade, whether it's due to suboptimal screening, suboptimal linkage, disparities in access to care, or even long-term follow-up to get routine HCC screening and surveillance. This is a paper published in Lancet a couple years ago using the Polaris Group consortium, and highlights some of the global disparities in the Hep B cascade. From the total population of Hep B, you can see here that only a fraction are estimated to be diagnosed. And of those that are treatment eligible, again, only a small fraction of those are actually estimated to be on antiviral therapy. A few studies in the US to illustrate these points and really emphasize low rates of hepatitis B testing and treatment among ethnic minority populations. This is a study published a few years ago that used the REACH US cohort that incorporated 28 communities across 17 states to look at differences in risk factors in delivery of care. They focused specifically on assessment of hepatitis B testing. You can see here in their total population, about 54,000, it was a pretty diverse population. You can see here, 40% African-American, about 31% Hispanic, and you can see here Asian Pacific Islander, American Indian, Alaskan Native. These patients experience suboptimal Hep B screening and testing. Overall, less than 40% were reported to be tested for hepatitis B, and even more concerning, of those with confirmed chronic Hep B, only a third received continuing specialty care, which has been a predictor of access to treatment and long-term follow-up. Another study looked at differences in access to specialty care. So you can see here, among patients diagnosed with chronic Hep B, what were the rates of linkage to specialty care? Very dismal. 24% in African Americans, 34% Hispanics, 41% in API, 19% in American Indian, Alaska Natives. Other disparities that this study identified, compared to patients with health insurance, those with no health insurance had significantly lower rates of testing and lower rates of confirmed diagnosis. The study also followed up and looked at other differences and found, in addition to race, ethnicity, and insurance, they also saw disparities by education, household income, and primary language. And this really emphasizes that while we focus a lot on race, ethnicity disparities, it's such a complex issue, and race, ethnicity alone is not the only reason that contributes to disparities. And in fact, is probably a surrogate for a much more complex set of social issues that we really need to be cognizant of when trying to address healthcare disparities. Low treatment rates, sorry, I'm trying to remove this box. Oh, there we go. Low treatment rates, low rates of timely diagnosis and treatment among insured population. This was a very nice study published last year in one of the JAMA journals that looked at the US Truven market scan data. And they looked at an algorithm and identified Hep B patients and identified only 30% of those with chronic Hep B received therapy. And again, they identified important disparities in access to treatment. Another one, this is a study we did in a safety net population, emphasized the same disparities among Hep B patients, which were very diverse in this safety net cohort. We looked at linkage to care and retention to care. And we observed that only 63% had successful linkage to care, and of those linked, less than 70% had retention. We saw significant disparities. Primarily African Americans and African Hep B patients had significantly lower rates of linkage to care. This is important because it translates into more severe disease at presentation. In our cohort, we found that almost 30% of patients had cirrhosis at presentation, and many of them already had decompensation, really emphasizing the importance of early diagnosis, linkage to care, and eventual treatment for these patients. Looking at treatment specifically in this study, was a multi-centered 4 safety net hospitals of over 5,000 patients. Among those that were eligible, just drawing your eyes to the bottom pie graph here, less than 50% actually received antiviral therapy. Furthermore, we found significant disparities by insurance status and also ethnicity. And while this was an observational study and difficult to determine the exact etiology, we know that from previous studies, these disparities likely reflect many different socioeconomic factors. Why is that important for timely diagnosis? Because it helps improve linkage to care, treatments, and reduces long-term risks such as HCC. Therefore, disparities in Hep B care that affect ethnic minorities and vulnerable populations further exacerbate existing structural barriers in timely access to care that these patients already face. Why is this important? Tying it back to HCC. Many studies, including this one, show that antiviral therapy, by reducing viral load, suppressing replication, does reduce the risk of HCC in Hep B patients. This was another study, a multi-centered real-world study that showed that antiviral therapy, as you can see here in the dark line, compared to patients that were not treated, was associated with significantly lower risk of HCC on 8-year follow-up. When they stratified by cirrhosis or non-cirrhotics, again, you see the significance in reducing HCC, emphasizing the importance of timely linkage to care and treatment. And so this is really emphasizing the importance in a Hep B cohort of addressing disparities, ultimately reduce long-term HCC risks. Moving on to Hep C, I'm not going to belabor this too much because I know many of you are aware of these data. This is really a study published a couple years ago that emphasizes the high-risk Hep C population we face in the US, including incarcerated individuals, drug use, homelessness, and really emphasizes the importance of understanding and addressing healthcare disparities that these populations face. Similar concept with Hep B, there's a very complex cascade from diagnosis to linkage to retention, treatment, cure, and long-term follow-up, especially patients that already have advanced fibrosis or cirrhosis. And as illustrated here, similar to Hep B, there are many unfortunate opportunities for patients to fall out of the cascade that need to be thought of when seeing the patients in front of you that's having difficulty with access to care. We've had some improvements already in the Hep C cascade of care. We've evolved from risk-based eventually to universal-based Hep C screening. We've also experienced significant improvements in Hep C therapy that have achieved high rates of cure, but we know that challenges still remain in linkage to care, particularly for high-risk and vulnerable populations. This is a study we published a couple years ago, including 4 safety net hospitals across the US, almost 30,000 chronic Hep C patients, pretty diverse as you can see here. Overall, concerningly, despite the availability of DAs during the study, latter part of the study period, only 17% of this Hep C population was treated in 2017. We also observed significant disparities. Here in the blue and red line, we observed that Hispanic Hep C patients had 52% less likely to be treated with antiviral therapy. And also here, when we stratified by insurance status, sort of as expected in that time period, we found that patients with Medicare, Medicaid, and of course who were uninsured had significantly lower odds of access to Hep C therapies. This is important because these primarily affect, again, those vulnerable populations, minorities, at-risk, and vulnerable groups that receive care within safety net settings. We also looked at something a little bit different, mental health diagnosis. And this is really important because many of our patients do have comorbid mental health and psychiatric disorders. And as illustrated here in the blue line, we observed that patients with underlying mental health and psychiatric disorders also experience significantly lower rates of Hep C treatment. So it's sort of a double, triple whammy to really think about disparities. Not only do they experience disparities due to low SES, also risk factors, but in the setting of having comorbid mental illness, this additive disparity of lower access to Hep C curative treatments is very concerning. As with Hep B, why is important? Time and time again, we've seen and shown that Hep C cure does reduce long-term risk. And particularly relevant to this conference, we know that Hep C treatment and cure, SVR, does significantly reduce the risk of HCC, as seen in this first figure on the left. Multiple other studies, the top one here is in the VA cohort, which shows again SVR associated with much lower risk of HCC. And then here, I believe it was in a French cohort, again, we found that Hep C therapy not only reduces HCC, but also is associated with a lower risk of Hep C related mortality. Moving on to surveillance. HCC surveillance is something I'm very passionate about in understanding disparities because it's one of the first and most important steps, I believe, in HCC Cascade. Because really you need to identify patients early in order to be able to offer them the most effective and potentially curative therapies. Unfortunately, time and time again, our studies have shown that HCC surveillance is suboptimal. This was a systematic and review, a meta-analysis published just earlier this year that included 29 studies globally and found that the pooled estimate of adequate HCC surveillance is 24%. I mean, 24%, really think about that. That means over 75% of patients that should be screened for HCC are not getting routine recommended screening. And that's really concerning because that directly translates into advanced stage HCC presentation and HCC mortality. And we know from US NCI cancer data that despite our improvements in liver disease care and HCC treatment, that overall 5-year survival from HCC still remains less than 30 to 35%. That's very, very concerning. HCC screening also has its own cascade. And this, I would argue, is a little bit more challenging because you really need to first identify patients who are at risk and need screening. And that in and of itself is a challenge. And we need to provide more education to patients and providers about that. And with HCC, one-time screening is not enough. You need to get your initial screening and have follow-up for continuous surveillance or follow-up of lesions that are identified. Following that, you need to be able to plug patients into specialty care to get access to potentially curative and also, potentially for patients that don't have small localized lesions, other treatments that can help reduce tumor burden and improve mortality. This is a very complex cascade, and there's many opportunities that we need to improve on helping patients transition effectively through this cascade to get diagnosed and to get access to treatment. Many studies have shown disparities, and here I highlight 3 studies. First, published many years ago at a single center safety net hospital, I believe in Texas, where African Americans were 39% less likely to receive surveillance versus non-Hispanic whites. In a large VA Hep C registry, we saw similar disparities. African Americans had much lower rates of HCC surveillance. And again, using the US National SEER Medicare data, African Americans have the lowest rates of HCC surveillance in this study at only 12%. I mean, these are very stark and concerning disparities, and we really need to do a better job at improving HCC surveillance in our cirrhotic and at-risk populations. Why is it important? Because the cumulative effects of disparities in a cascade of HCC, as I mentioned, lead to more advanced tumor at diagnosis, which leads to fewer options for curative therapy and ultimately lower HCC survival. Therefore, disparities in the cascade that affect ethnic minorities, which we've seen in the literature, and vulnerable populations, they further exacerbate existing barriers that these individuals already face in access to healthcare. And this is really, I'm not going to read this, but just to emphasize that it's so complex and it's such a multifactorial consideration in trying to understand what are the barriers. Certainly there are patient factors that contribute to it, provider factors, but also system factors. And really any attempt to try and understand and address disparities in care need to comprehensively understand and also incorporate all aspects of patient, provider, and system level factors. Mitigating disparities in liver disease. We know that disparities arise from multifactorial contributors, as illustrated in a previous slide, and they're really compounded by the complexity of liver disease care. I mean, we're just talking about HCC screening, but the critically ill patients with cirrhosis and the complexity of the management further exacerbates the difficulty and challenges in trying to manage these patients. We know that these patients are high risk and vulnerable populations. We also know from prior experience and studies that there's no one size fits all. We can create models and create algorithms, but we need to understand the individualism of patient experience, their background, their SES, their culture, understanding, and we really need to incorporate a multi-pronged approach if we're going to be develop effective interventions to address these disparities. And really it comes down to education, integrating effectively in a system level potential interventions, and really trying to innovate and think outside of the box from what we're already doing to address the challenges and disparities that we currently face. So take-home points, hopefully I've illustrated that chronic liver disease predominantly affects ethnic minorities and underserved vulnerable populations. The liver disease care cascade is complex, and it's particularly complex in many ways, a fractured healthcare delivery model. Disparities in liver disease care are multifactorial and reflect patient, provider, and health system barriers. And a comprehensive approach is needed that incorporates education, integration, and innovation in healthcare delivery. And thank you so much.
Thank you so much, Dr. Wong, for that fantastic and comprehensive talk. I think, as questions come into the chat box, one of the things that really struck me was just the, third to last slide on complexity. And I think that we need to think about the denominator here, because so much of what we understand is just the patients who actually come in for hepatitis B and C testing or come in to have their screening. I think the denominator is probably much larger. And so given the audience of patients and caregivers, and knowing that research is moving more towards having the patient voice, I'm just wondering, what are some of your thoughts on how we can move the needle in improving access to care and really understanding the denominator?
Yeah, that's a great question. And I think he illustrates such an important point. A lot of these studies sort of forget the missing population, all of those that are not linked to care, not being evaluated. And, depending on which disease you look at, that population is vast. And I think that research and advocacy is certainly moving towards recognizing the importance of the patient voice and patient advocacy, and advocating for education, access, resources. I was just on a call, I forgot yesterday or the other day, but programs like the Global Liver Institute, which is a huge patient advocacy group, I think are doing amazing things in educating, but also I think arming patients with the resources to ask the right questions. Ask questions about their care. What should they do? What should they be aware of? Because when we engage patients, I think ultimately it helps improve the care that they receive.
Yeah, I think it's important to note, I mean, among all the foundations that are dedicated to liver disease, so there's ALF, GLI, there's a number of local foundations that are really trying to get patients and just people in general. I mean, I think that our bias as physicians is that we always think about our patients, right? Because that's who we take care of. But I think to really move the needle from a population health perspective, we really need to get active in policy and really understanding that preventive health and the fact that, while we have long since talked about vulnerable or marginalized populations, bringing normalcy to things like testing for hepatitis B and C in everybody over 18, those types of population health and public health measures, I think will not only make people more amenable to coming forward to get care if they need it, but also there's no stigma associated with, when you have, a government, like the United States Public Health Services Task Force say, listen, everybody over 18 should get a one-time test for hepatitis B or C, then it just becomes part of routine, health maintenance, right? And so all of that stigma, I think, is then diminished. So I think that's really important, is to understand that population health and to move the needle on preventive health requires a normalization of what were probably erroneously stigmatized, risk factors in the past.
Yeah, I think I love what you said, because it's so important to normalize, because we've seen time and again with HIV and Hep C that risk-based screening has really failed. And it's, we've seen Hep C evolve, and I hope with time and very soon that we'll have the same evolution with hepatitis B, and I do think that we should implement similar measures as we have for Hep C to test all for Hep B, to really, as you said, normalize it, not create stigma, but also capture the many, I think, Hep B patients that are underdiagnosed and unaware, in the US.
Right. And I think it's really important, the take-home message with Hep C is that, over 30% of patients who are diagnosed with Hep C have no earthly idea how they got it.
Yes.
And I would say it's the same probably for hepatitis B. And so, I think it's really important just to underscore how so many people are missed, and that how it's totally reasonable to say to your doctor, hey, I'd like to have this test for hepatitis C, or I'd like to have this test for hepatitis B. And so I'd really like to arm the people listening to go ahead, ask. It's fine. There's nothing wrong with that.